Good morning and welcome to today's webinar, COVID-19 Developments, Fact and Fiction. My name is Linda Saunders. I coordinate the National Online Education and Support Programs here at the Leukaemia Foundation. Working alongside me today is my esteemed colleague, Jane Manning, who coordinates the development of our information resources here at LF. We will be hosting today's webinar. Before we commence formal proceedings, the Leukaemia Foundation acknowledges this webinar is being delivered from the lands of the Wathaurong people of Geelong, the Yugambeh people of Logan, the Gadigal people of Sydney. We also acknowledge the traditional owners of the various lands from where you are viewing today. We recognise their continuing connection to the land, the sea and the community. We pay our respects to their elders, past, present and emerging. So we would like to start by taking a moment to acknowledge everyone who has been impacted in some form or another by the COVID-19 pandemic today or over the last 2 years. There have been many challenges to face, and we've heard from many of you describing the broad-ranging and varying effects on your physical, emotional and financial health and well-being. We understand you have many questions related to COVID-19, and we recognise that many people living with blood cancer are looking for trusted sources of information to help make informed decisions. With so much information available, it can be really difficult to decipher what is relevant and reliable information, particularly as the nature of the pandemic evolves, meaning the information also evolves and changes with it. This can be incredibly hard to keep up with, both for people living with blood cancer and for health professionals alike. So for today's webinar, we have asked you, the audience, to tell us what you would like to hear about. In doing this, we hope you gain relevant information that you may be able to apply to your own individual circumstances. So as you can imagine, we have received hundreds of questions, and inevitably we are unable to answer each specific question directly. We have, however, identified the key themes amongst all those questions, and we've shared these with our guest speakers. Here are the top themes that we have collated from the questions that you submitted. Risk of COVID infection, the management and treatment of COVID illness. Obviously, this is all in the context of people living with blood cancer. The vaccination schedule for both adult and the paediatric and adolescent population. The immune response to vaccination. New drug products, and that's related to both new drug products of vaccinations and new drug products to treat COVID illness. Infection prevention strategies that sit out obviously outside of vaccination, and long COVID. So without further ado, I'd like to introduce our two guest speakers, clinical haematologist, Associate Professor Nada Hamad, and Paediatric and Adolescent Oncologist, Associate Professor Antoinette Anazodo.
So what I wanted to do today was really try to address as much as possible the questions that have come through. And, the outset, I'd like to say that as hematologists, we really love to leverage precise medicine and personalized medicine. And whenever there's questions we can't answer where we have to use generalized information, it makes us all very anxious. And I think that also translates into patients not being used to getting information that's very general. So as much as I can, we will try and tailor the information that we can for you as an audience, but acknowledge also that it is not specific enough. And really in the community, we're trying very hard to be able to answer those questions. My first slide is about acknowledgement of stress. Now, and this may be stress of patients, but also stress for clinicians. The pressure of the COVID pandemic has been unrelenting. There's uncertainty with so many unknowns, both as a citizen of the community, a member of the community, but also as a clinician and also for patients. There has been so many changes in public messaging, so it's very hard to keep up, as Linda has mentioned. And there's no real clear end in sight, which can make it very challenging for people around us, for the community, for society in general, to manage the anxiety and stress and pressure of the pandemic. There's clear data out there that shows that patients and clinicians both have underlying stress and anxiety around the pandemic. There are concerns from patients with blood cancers and immune-compromised patients around the community spread of COVID and what that means for them. There are worries about what happens if you get sick, and if that means you might be dying alone or you might not have access to your loved ones. And from a pediatric perspective, there's lots of concerns around how you go to school, what do you do with kids who are vulnerable. And at this point, I'll just ask Antoinette to chime in and give her perspective of a pediatrician around the pressures of COVID.
Yeah, so, across different ages, there's certainly lots of core themes, but in our younger patients, so the under 12s and then the older 12s, what we see is sort of three groups of concerns. So the concerns for safety within families, issues with peers, and the lack of celebrations of rites and passages that are so important when you think about adolescent development. And then it's school. And initially, when we thought this pandemic was going to be a short period, there were certainly recommendations that were made about school. And as we realize now that the pandemic has been much longer than we all had certainly thought, and certainly we've all wishing that it was going to end very soon, we see that change doesn't necessarily mean that there's changes in practice when it comes to isolation. And so for many of the young people, that's had an impact on mental health that we're seeing with over an increase by about 22% in young people in general seeking psychological and psychiatric support, which is a concern because that's probably the tip of the iceberg of patients who are at the sort of more extreme end in symptoms. So something that we're going to have to watch out for. And I guess the other issue in terms of acknowledging stress is the stress of being in a hospital without support. And so for many of our patients, especially those teenagers who think they're quite independent, being on their own, especially if you're the sort of 16 to 18-year-old that could be treated in an adult centre, means that they haven't actually had a support person for a long time. And so have they always been able to advocate for themselves or have advocation from family members? So really, really important.
Thanks, Antoinette. So what I wanted to do at the outset is to briefly go through how the immune system works. So I think it underpins the conversation we're going to have, and why blood cancer patients are specifically vulnerable to COVID and its effects. So the blood is made in the bone marrow. The origin of cells in the bone marrow, or the original cell, is called a stem cell. And I'm hoping that you can see my arrow so that hopefully you can follow me on this journey explaining how this works. So stem cells differentiate or mature to become the cells your body needs. Over time, your body can lose cells because they've gotten older, and so they need to regenerate to create the components of blood. There are two arms. There's the myeloid arm on the left and the lymphoid arm on the right. And the myeloid arm creates the cells that are the composition of your blood that most people understand. So the red cells that carry oxygen, the white cells that protect you from infection, and there's different types of white cells. And some of these white cells, such as the neutrophils at the bottom of the left here, they protect you from bacterial infections. So it's a very important part of the immune system when you're vulnerable that you don't get infections from bacteria out on the world or just living on your skin or in your gut or in your body in general. On the other side is the lymphoid system. This lymphoid system is a very sophisticated system and probably mostly important for viral infections. What happens is that these lymphocytes mature and move out into the blood and go into the lymph nodes, which are the glands in your body. And sometimes if you notice, if you get a cold or a flu, you'll feel the glands on your neck swelling up. That's the lymph nodes multiplying in an attempt to fight off a virus that's been exposed to in your throat, for example. Even these lymphocytes have multiple journeys. So some are designed to create antibodies, and antibodies fight off infections very specifically to a specific virus. So if you're exposed to a virus or through a vaccine that mimics a virus, these antibodies are designed to attack cells infected with that virus. There's also a different type of lymphocyte on the left, that's a T lymphocyte, that doesn't make antibodies, but it is very good at killing off cells infected with a virus. And this entire system works in harmony. So the B lymphocytes that create antibodies, the T cell lymphocytes that are designed to fight off infected cells, but also the neutrophils that make sure that during a period of vulnerability, such as a chest infection, doesn't occur with a bacterial infection on top of viral infection. So some of you may have experienced this, you get a cold or a flu and you're getting a bit better, but then you get a bit sicker and you end up with pneumonia. That's if your neutrophils are not doing a good job of fighting off bacterial infections, you can get what we call a superimposed infection. So if you think about it, the source of all hematological problems is a dysfunction somewhere along the lines of the system. You know, some patients may have an abnormality in the original stem cell right at the top. So everything downstream from that is affected. Some may have impacts on the left side of the system and some on the right. And some people might have implications in both, whether they're affected because of other comorbidities, other illnesses on top of their blood cancers. So this is why blood cancer patients are quite vulnerable, because if their immune system is affected in any one of these areas, they are vulnerable. And the most vulnerable are those who have, you know, leukemias where the original cell is abnormal, and those with lymphomas where they're not able to make or mount an antibody response or a cell response. In terms of the impact of COVID and what it can do to the body, it's really important to understand that COVID is a virus that's a multi-system virus, and the variants do different things to different parts of the body. And if you were to listen to the news or Google COVID, you can see a lot of this. I don't put this up to go through every specific impact of COVID, other than to demonstrate that COVID can affect multiple organs, which is why the impact can be so variable in so many different people. Every organ is susceptible to infection and to damage from COVID, including blood vessels and including the lungs, which are the ones that we get concerned about the most, because if you get an infection in the lungs with COVID, obviously oxygenation becomes a problem, and this is why some people may need oxygen supplementation or intensive care ventilation. And of course, blood clots have been in the news a lot for a variety of reasons, but that's also a problem with COVID, especially in people who have underlying conditions related to any of these organs. So if you have a problem with your heart, you may be more susceptible to the impacts of COVID in that organ. So what about specifically patients with blood cancers? What is the risk of COVID for you? And a lot of questions came about around this. You know, what are my risks? What would happen to me if I got COVID? And I really wish we could answer this question. But I will reiterate that blood cancers result in immune dysfunction for the reasons I explained before, because the disease itself renders the body immune compromised. And in some instances, the treatment itself can also render you immune compromised or even more immune compromised. And it may be a combination of both. You may not have been immune compromised prior to treatment, but because of your treatment, you now are. It is very difficult to determine an immune competence, as in the strength of your immune system, for any reason. This is not a test that we can check for as doctors. This is not something you can assess for, but there are ways to measure certain elements of the immune system. So we may look for neutrophil counts to make sure the number of neutrophils you have is good enough. And some of you may have experienced that conversation with your clinicians around your neutrophil count. Antibody levels is much harder to establish, but some of you may have required supplementation with intravenous immunoglobulin or other globulin supplementation because you've had low levels and multiple infections in the past. So there is very cursory ways of us assessing that immune competence, but really in a very non-specific way. And so there are many unknowns. It's very hard to know which diseases are most vulnerable, which treatments render you the most vulnerable, and when in the course of your disease and your treatment are you either most or least vulnerable. We have some information that makes it easier for us to make an educated guess, but specifics are much harder to come by. COVID poses a high risk of death and serious complications in patients with blood cancers, and there's unknown risks as new variants emerge. So, as variants come along, we still don't know the impact for the general public, let alone specifically in blood cancer patients. So most of the data we have are from the original wave or the Delta wave, but not so much from the Omicron wave. So when my patients ask me, well, what is my risk and can I do X, Y, and Z? I often have to say, I'm basing my information on Delta. I don't know about this variant, and I certainly don't know about future variants. So the studies that have come through today, if you Google COVID and blood cancers or hematological malignancies, you'll get a lot of information. There's been a lot of studies looking at the outcomes in these patients. And in 2020, there was a meta-analysis, which is a pooling of all of the studies together to get as much information as we can. And this was published at the end of 2020 in the Blood Journal. It's an analysis of over 330 patients, over 3,300 patients. And this is a diagram just representing some of the findings from that. So in terms of risk of dying in patients with blood cancers, in adults, it looks about 34%, but in pediatrics, it's much lower, a 4% risk. So the information we have in terms of pediatric outcomes is not as robust as with adults. And I'll get Antoinette to comment on that briefly in a moment. Adults over the age of 60 versus adults under the age of 60, this reflects the general public outcomes as well. But you can see up to 47% in patients who are over 60 with a hematological malignancy. So the risk increases the more risk factors for COVID you have. So you've got an underlying malignancy, you're older, if you have other comorbidities, it's even worse for you. Recent anti-cancer treatment, again, there's clearly an impact. So if you recently had chemotherapy or treatment for your hematological malignancy, you're at higher risk than not, but still in both situations, looking roughly around 30%. And of course, other disadvantaged groups also seem to be more vulnerable and more at risk. So comparing white patients to non-white patients in the US, it was found that there's increased risk in that group as well. I'm going to very briefly show you the data from that study that looks at specific diseases. What I want you to focus on isn't so much where your disease might be in this list, but to generally look at the number on the left in red. It's on average around 30% or more. So 30% or more is roughly where we're at for any hematological malignancy. The numbers on the right are what we call confidence intervals. So the true number lies between these two limited results. So if it's 53%, the true value sits between 34 and 72. And in most cases, that number is pretty close to 30%. So if you were to take anything away from that, if you have a hematological malignancy or had a transplant or had CAR T-cell therapy, your risk of dying from COVID is roughly 30%. So the finer detail is not that important other than to say it's very clear that there's a signal of increased risk of dying from COVID, particularly in the Delta wave. And you remember, although we have Omicron, Delta is still circulating in the community. Now, I'm going to throw back to Antoinette for her to describe the pediatric experience, because that's very different to the data that I've presented here in adults.
Yeah. So thank you, Nada. So look, the data for children and adolescents is a lot better, and I think some of that is because the children and young adults tend to be healthier, even if you consider their cancer diagnosis. They're less likely to have what we call comorbidities, which essentially means other health problems. And so when you look at the data in adults and then try and compare it with children, what we're not seeing is an increase in patients who are overweight, an increase in hypertension, an increase in cardiac, respiratory or renal disease, and a history of previous clots. And I think that is really important when you think about risk factors. It's not just having the cancer, it's also about your general health and something that your clinician and you have to take into consideration when you assess your own risk. The other thing for children is certainly with Delta and now with Omicron is that across the board in all of the blood cancers, we're seeing a much lower incidence of children without cancer and with cancer presenting with COVID. When they do get COVID, it is true to say that they tend to be more symptomatic than non-COVID children and adolescents of the same age, but they don't seem to have, based on the evidence to date, the worst outcomes in terms of admission to ICU and deaths as a result of COVID, which is very good.
Thanks, Antoinette. So what do we do with the knowledge that we have? What do we do with the limited information that we have? Vaccination still appears to be one of the cornerstones of protection. Certain diseases and drugs can reduce the probability that you will develop a response to the vaccine. If you recall, we talked about lymphocytes that develop antibodies to viruses. The way vaccines work is they introduce a small part of the virus it's trying to mimic, and then your body creates antibodies to it, so you are protected even though you don't get the infection. The mechanism of different viruses is slightly different, but the principle is the same, and we may be able to touch on that later. But for the purposes of this discussion, if you don't respond to vaccination, there's questions about whether you would respond if you received a second, a third, fourth dose, etc. Now, in hematological malignancies, the response rates to the vaccine, the double dose vaccine, can be as low as 20% and as high as 50%. And it's not very clear who will respond and who won't. Even though statistically it appears patients who have had recent treatment are less likely to respond, and it appears 6 months from treatment, vaccination 6 months away from treatment increases your chance of response, it's still not very clear. So we're still vaccinating as per usual. We also know that with more doses of vaccine, the more chances more people will respond. Because if your immune system, for whatever reason, is suppressed today, in a couple of months, it may be slightly stronger for whatever reason. And the more exposure you have to a particular virus, be it dead albeit dead in a vaccine, the more likely you're going to develop an antibody response or a cell response. This is why we encourage patients to get vaccinated and get the full course, including the boosters. And we'll talk about boosters in a moment. The current vaccine studies we have available have limitations. Most of the very big studies done for the main vaccines we have on hand, so AstraZeneca, Pfizer, the Janssen & Janssen vaccine, Novavax, all of the vaccinations that we have were mostly studied initially in healthy individuals. And as time went by, they started to analyze responses in patients who were immune compromised. But the data is coming in small numbers, and because blood cancers are rare, and all of the patients with blood cancers are at various stages of diagnosis and treatment, it's very hard to make specific conclusions. So I often have patients who will say to me, you know what, I'm 3 months after starting treatment with X drug. Does that mean I'm protected or not? And I can't quite answer that. All I can say is, well, we do the best that we can, and we try and vaccinate you to the best of our abilities. So the question of best timing of vaccination, the efficacy of the vaccine in specific populations or specific patients, And how to assess the response to vaccination still remain unknown. We still don't know the answers to those questions, and we're working very hard to find those answers out. With additional doses, like I said, more and more patients respond, which is why for patients who with blood cancers, we are advocating for 3 doses as a minimum and then proceeding to a 4th. And I'll talk about that in a second. There is no concern regarding the safety of vaccination in patients with blood cancers, which is why it's a low-risk endeavor. So even if you are unlikely to respond or we're concerned about response, it's still preferable to get vaccinated because on the balance of risk and benefit, you're in a better position if you benefit in the smallest way possible compared to the risks of the vaccine. A lot of questions come through about mixing vaccines and whether that's an advantage. In the general population, there's some early data to suggest if you had multiple types of vaccines that you may have an added benefit or advantage. But that is not necessarily the case for all variants. So we still really don't know the answer to that question. And it is certainly not clear in patients with blood cancer. So, from a practical point of view, whatever vaccine you can get in the appropriate time frame, that's the best vaccine. The interval of vaccination has been very confusing for various reasons. So in the news, when we talk about boosters and we talk about vaccination schedules, those schedules don't apply to patients who are immune compromised or patients with blood cancers. So as per the ATAGI recommendation, for patients with blood cancers, 3 doses is the standard, and then you're eligible for a 4th. The first 2 doses are usually either 3 to 8 weeks apart, depending on the vaccine that you've got. But beyond that, the 2nd and 3rd dose, between the 2nd and the 3rd dose, that's 2 months apart. And the 3rd and 4th dose, the recommendation is 3 months apart. If you've received a transplant or CAR T-cell therapy, you need to start vaccination from scratch, even if you were fully vaccinated, even up to 4 doses before the procedure, because those procedures really do obliterate your immune system. So we have to start from scratch. And the recommendations around when to do that can vary depending on the situation. Donors are advised to get vaccinated prior to donating, and recipients are also advised to do the same. So in most cases, if you are about to start treatment for your blood cancer or you're about to have a transplant or CAR T-cell therapy, we're recommending that you try and get fully vaccinated before that, if possible. Sometimes your disease may be too aggressive to do that, or there may be urgency, so we're not able to deliver all of the doses prior to the procedures or the treatment. And in that case, that is something that's decided by your clinician and yourself. In terms of bone marrow transplant donors, it's always advantageous to be vaccinated to protect the donor, but also potentially to transfer some kind of immunity to the recipient, if possible. We don't know the answers to whether this is preferable or poses an advantage to the recipient yet, but that data will come in time. Now, the intervals can also change, and this is why it's really important to ask specific questions about your case with your healthcare providers. The intervals between vaccines can vary depending on the community spread and how soon you need to be treated. So it's important to address this question depending on the public health stresses that we're experiencing or your individual disease. And as an example of that, there's been recent changes in the dosing for children with immune compromise. And I'll throw back to Antoinette so she can talk about that briefly.
Yeah, so as everyone knows, on the 10th of January, children from 5 to 12 were eligible for Pfizer vaccination. And at the time the program opened, there were no recommendations for immunocompromised children. And it really, in all states apart from WA, was the height of the Omicron vaccination. So I was certainly very concerned as we started to see an increase in children being diagnosed with COVID that we hadn't seen in Australia. And we made representation to ATAGI and the health minister. And as of the 17th of February, the dose scheduling has changed. So now immunocompromised children who are defined as children who are having cancer therapy or who are in remission within 12 months, or are bone marrow transplant patients who completed treatment up to 2 years ago, are eligible for the schedule to change. So rather than 8 weeks between the first and the second vaccine, it's now 3 weeks. And if you were part of the initial schedule, you should be able to go back to the centre who gave you the initial vaccine and change the appointment, because many of those children are now eligible. And the other thing that has been added as per the FDA recommendation is the third vaccine for this age group. So very importantly, mirroring the AYA and adults, that third vaccine you'll be eligible, or your child will be eligible from 2 months after the second shot. So that's something that, you know, some of our cancer patients may not understand at the moment.
Thank you, Antoinette. So, questions about whether you responded to the vaccine or not. So many patients really want to know if they responded or not, because they feel that if they were aware of this result, it may change how they behave in the community, or the risks they may be able to take, or just for peace of mind, or for, you know, for whatever reason. Lots of people want to know. At the moment, there's no evidence to support using antibody testing, because the testing for antibodies is based on those who are infected with COVID. It's not fit for the purposes of answering questions of whether you've responded to the vaccine specifically or not. The other problem is, if you have antibodies, how high is high enough? Now, with other antibody tests, we have a threshold. We've developed strategies to say, you know what, if you reach this level of antibody, you're protected from hepatitis B, or if you reach a certain level of antibody, you're protected. But we don't know what that threshold is for COVID. So even if you have a positive result with antibodies, how high is high enough for me to be able to say, yes, I believe you are protected? So the test isn't answering the question that's being asked. Now, are antibodies a surrogate for anything in particular? Does it actually tell me something about your immune system? Now, yes, the answer to that is yes, and it does reflect the humoral response. If you recall, when we talked about those B cells that make antibodies, it is a marker of that response, but it's not a marker of the T cell response, and both have a role in COVID immunity. So it's really important that we don't miss that piece. So although you may not have a humoral response or an antibody response, you may have some protection from the vaccine from the T cell response you get from the vaccine. So at this stage, the recommendation is that we do not do testing for antibodies in blood cancer patients. It is not either cost effective or relevant from a doctor's clinical perspective in decision making. So a test that doesn't help you make decisions and a test that doesn't answer a specific question is not a good test to do. So we just not doing it. Some people are doing it, but it's not backed by evidence, and certainly is not based on any international recommendations. So if you did respond, let's say you're one of those people who got a test that says you had a response, does that mean you are protected? Well, the answer to that is no. Nobody really knows how long your antibody response is going to last. There is evidence that immunity or antibody levels to COVID, whether it's from infection or from vaccination, wane over time, which is why boosters are important and why boosters have been extended to the rest of the general public and community, and not just for immune-compromised patients. And we talked about how high is high enough in blood cancer patients. We don't really know the answer to that. You know, is it the same as for healthy populations? No one really knows, and nobody actually knows the level in healthy populations either. The other problem is we don't know the implications of variants. So even if you have an antibody response and you were infected, let's say with Delta or had vaccination, doesn't mean you're protected from infection with a different variant. So again, not a test fit for purpose. One of the questions a lot of my patients ask after being exasperated with the current ever-ending story is, will I ever have a life? What can I do to protect myself? You know, especially with the public messaging where the world is relaxing, restrictions being lifted, does that mean you can do the same? And the answer to that is yes and no. I think it's really important to be sensible and cautious and advocate for yourself. You're the only person who understands your own vulnerability. The rest of the world is not living your life, unfortunately, and is not going to consider your specific circumstances. Hand hygiene is good for everybody, and so that's an easy thing to do. Social distancing remains a cornerstone of protection from COVID, and the new emerging data suggests ventilation is very important. And in fact, there's a lot of evidence to back that up. Masking is extremely important, especially as other people stop masking, right? So if everybody around you is not masked, you ought to be masked. AusSage is an organization that has developed significant resources that are very well researched and resourced. I would encourage you to look at that website, aussage.org, especially about masking strategies in the community and ventilation strategies. Work and events. Mask as much as you can, even if everybody else is not. Ask about the vaccination requirements for the people attending or the people around you. Ask about rat testing for those attending or those around you, or what are the requirements for that, and ventilation. If you're going to an event in a very small quarters with no ventilation, no windows, it's probably not ideal. If you're going to an event where there's no mandate for vaccination or strategy around making sure people are vaccinated and no one is rat tested, you might want to think twice, depending on your own personal circumstances and your affinity for risk or aversion to risk. Everybody's different, so you got to do what's right for you. I get a lot of questions about travel. And my advice about travel is consider where you're going and your access to healthcare. Are you going to be looked after like you would be in Australia if you were home? What are the vaccination rules to where you're going? And what are the ventilation strategies in those areas? And by ventilation, I don't mean just open windows. If it's, hotel rooms, etc., is there filtration of the air systems? Are you aware of any of those issues? And I would suggest that you need to ask about those. Antoinette, I'll defer to you for school, because school has been a major issue for personally and professionally for all of us. So
Yeah.
what are your thoughts about school?
So I'll just add one thing, which is insurance. So for most families, they'll find that if they do want to travel, whether that's interstate or overseas, their insurance won't cover COVID. And I think while we are so fortunate to be in Australia and having good healthcare around our state, going overseas can actually be a very, very expensive problem if you do get COVID. So I certainly of the opinion at the moment that unless you can get insurance, you should probably put those trips on hold if you're in the acute phase of your illness, because we're seeing much higher rates of COVID elsewhere. And that's something absolutely you should discuss with your clinician, because it will vary from a patient to patient. In terms of schools, well, I think the advice has changed. When COVID started 2 years ago, we were super cautious, and the schools really had no recommendations. There was no testing. But over time, what we found is the schools have had to adopt an infection control protocols, which is out of their scope, but most of these schools have taken that on board. The government has also made recommendations in terms of rat testing. So I would say to the children of our adult cancer patients or our childhood and adolescent cancer patient families, the first thing I would do is have a conversation with the schools about what they have in place, and also depending on the area you live in, what the vaccination uptake looks like, because I think the risk is going to be very different. I think that if the school is on board with all of the sort of sensible, cautious approaches that Nada has discussed, that in many patients, maybe excluding our early bone marrow transplant patients, it would still be safe to attend school. But this is not going to work for everyone. So I think you've got to take your situation and your child, not only their cancer cancer story, but also the comorbidities I talked about. In addition to cancer, do they have, lung disease or heart disease or renal disease, things that may make a COVID illness much worse?
Thanks, Antoinette. And I am seeing some messages on the chat about masking, and my suggestion is to please look at the Aussage website, because mask comfort is really important. Finding the right mask for you and the appropriate mask is really important. And we won't discuss that specifically today, but there are very different types of masks that you might find more comfortable. The thing that I'd like to end on in this slide is ask. If you are comfortable to share that you're a vulnerable individual because you're immune compromised, please do so. Tell people, give people the responsibility to support you and to protect you if they can, and always ask questions, because no one else is going to do that for you. And so the questions around what happens if you're COVID positive. If you have mild symptoms or you're not even symptomatic at all, please tell your healthcare provider, which is usually your hematologist, as soon as possible. There are some treatments out there that you can receive, but these are time sensitive. We have 5 days to be able to deliver those treatments. And the most common treatment available right now is called sotrovimab. This is an antibody that is an external antibody to your own. It binds to the virus and stops it from infecting your cells and helps you fight off already infected cells. So this is a reasonably effective strategy. It's a single intravenous dose and it's given over 30 minutes. And some hospitals are even delivering it to patients at home. But if you don't let us know early enough, it's very hard and challenging to give it. So I'd rather know if you've developed COVID. And so my recommendation is to please tell someone. And if you do have more severe symptoms, if you're feeling unwell, you're getting high fevers, you're breathless, you need to present to hospital. Again, this is time sensitive because the earlier you start treating COVID, the better. There are multiple drug options. Some of the time we use it in combination, and sometimes you may use 1 or 2 of the drugs, but dexamethasone and remdesivir are very common treatment options. Dexamethasone is used for its anti-inflammatory effects in the lungs to stop the development of pneumonitis or inflammation in the lungs and the need for oxygen. Remdesivir is an antiviral agent that's been shown to be effective, particularly in combination with dexamethasone and other agents. Baricitinib is also an alternative anti-inflammatory agent. The same goes with tocilizumab, which is also available, and sarilumab is a antibody-based agent. So not all of these are indicated or applicable to everybody, but doctors are very good now with protocols to figure out who should receive what. Certainly, sometimes patients with kidney dysfunction or other organ dysfunction may not be able to use one drug or the other. But it's always best that if you feel unwell to come into hospital and at the very least let your hematologist know. So what are the longer term issues with COVID? In patients with blood cancers, one of the challenges is not being able to clear the virus. So if you're not clearing the virus, it can go up in levels. So you can get, COVID that lingers on and then goes up and makes you sick, or sometimes it comes down, and so on and so forth. So over time, it can rear its ugly head and cause recurrent disease. So you may be susceptible to symptoms over a long period of time. And if you don't clear it, you may be sick with it for a long time. If you develop severe disease, obviously you may need ventilation or oxygenation with invasive ventilation with a ventilator in the intensive care unit. And that is a really challenging situation because recovery after intensive care in its own right is not easy. So recovering after severe COVID can take quite some time, and in some cases from weeks to months. Long-term organ dysfunction, or what people are referring to as long COVID, is persistent symptoms over a very long period of time. And those symptoms can vary. And you can see here, I didn't put that here as an exhaustive list, but it's a list to show you that it can really manifest in different ways. For some people, it's difficulty breathing. For some, it's a cough, tiredness, aches and pains, and even depression, anxiety, and difficulty thinking clearly over time, especially with issues around memory. So long-term impacts of COVID are probably a result of it being a virus that can affect all of your organs. And so that's why we're seeing these syndromes. Now, One of the other challenges I have in explaining to patients with blood cancers is the concept of reinfection. So let's say you had COVID, you recovered, everybody around you got it in the house, and now everything's okay in your household, but you're starting to feel sick again. Can you get reinfected with COVID? And the answer to that is most definitely. You can get reinfected with Omicron multiple times or different variants. So you may have had Delta and then get exposed and infected with Omicron. And particularly, this is a problem in patients who have not developed a vaccine response or are more vulnerable because of their immune compromise, as we discussed below. So if you do get reinfected, don't assume because you've had COVID before that this is not COVID. If you have symptoms of, any kind of symptoms, headache, runny nose, sore throat, it could be COVID again. So you need to, again, do the same things we discussed, contact your healthcare provider or hematologist. A lot of patients were quite afraid of going to hospitals because of how much COVID was in hospitals. It's really important to appreciate that hospitals have really stringent strategies to protect you and healthcare workers. We're trying to make sure everyone is protected as much as we can. There's so many policy variations between hospital and hospital. So your best bet is to ask about rat testing in your hospital, the visitor and support persons policies, the strategies to protect you from COVID. If you don't ask, you won't really know the extent of the restrictions. And also because community spread is various across Australia. So not all the states have the same strategies. We are under pressure as clinicians. I will not lie. This is the busiest I've ever been. But at the same time, I acknowledge we are all your advocates. Your hematologists are there to support you and will fight for you no matter what. So please ask if you have questions, and please tell us if you're unwell. Do not delay if you're not feeling well or you're COVID positive to get in touch with us. Many patients want to know, what is the future going to look like if we're going to live with COVID? So what is there out there to protect you? So the best way to protect yourself is do the things that we talked about before as much as you can. There are new treatments that are emerging and evolving, which is excellent. There's been provisional approval by the TGA, but that doesn't mean that these drugs are available yet. So molnupiravir, I can't even say it, molnupiravir and Paxlovid are something that you may have heard about in the community. These are important drugs that have shown efficacy in treating COVID, but they are not easy drugs to deliver as clinicians because there's so many drug-to-drug interactions where you can't have one drug with potentially the treatment drugs that we're using in blood cancers. And some patients who have organ dysfunction, particularly kidney and liver dysfunction, may not be able to tolerate those drugs. So they're not exactly the only things available and they'll save everybody. They have their place and their role. So the best way you can minimize the future risk is to continue to self-protect. Prevention strategies are certainly very attractive. A new drug out and in use in the US is called Evusheld, and it's an antibody-based treatment for patients who don't have their own antibodies to COVID. It has been shown to reduce symptomatic infection by 77%, and the protection lasts 6 months. So it's got excellent prospects. But these results are based on Delta, and the results for Omicron are still pending. It's received provisional approval by the TGA, and so it's still not available in Australia. And even if it were, there are likely going to be limitations on supply, and it's still not a substitute for vaccination. So, although it might be available, you still need to be vaccinated, and the access is not necessarily on the horizon immediately.
Nada, can I just make a comment? I think there has been a few people in the chat who've asked about specific drugs for them. I think one of the things, the acute patients, most of them will have contact with either their clinical nurse consultants or their clinical nurse consultants or their specialists, and they will get quite timely advice. But there's a cohort of patients who are either on novel agents taken orally and they see their clinicians less frequently, all those patients in maintenance. And I think the first thing to say is, if you are tested positive for COVID to contact the cancer centre to get advice. And then Nada has spoken about lots of different options. Unfortunately, those options in terms of availability will vary depending on the cancer type and situations in terms of your comorbidity, so your general health and your blood count. And so not all of them are going to be available to you. And certainly in some patients, like paediatric patients, we've found that the patients have recovered so quickly that they haven't needed any of these treatments. So really important, I think the real main message to get to everyone is, if they do test positive, don't obviously, you know, I'm sure you'll be concerned, but contact the cancer centre so they can give you individualised advice about what you'll be able to access in your cancer centre and the timing of that.
Thanks, Antoinette. Absolutely. And, you know, one of the things to remember is that although these agents are coming through, we still have to think about variants emerging and community spread and the efficacy of these agents in the face of that. At the moment in Australia and around the world, we're trying to answer some of those questions that I said, you know, earlier that are still unanswered. There is a study called the SERA-OZNET study, which is looking at vaccine response in immune-compromised patients. And this is gratefully supported by the Leukemia Foundation. If you haven't been vaccinated yet and you would like to be vaccinated, I'd highly recommend that you consider enrolling in that study to help us understand vaccine response, particularly in patients with blood cancer. There are studies around the world specifically looking at subsets of hematological cancers. Waldenstrom's data coming through a study at Concord Hospital here in Sydney, and that should be available soon. There's a study in Queensland specifically looking at T-cell responses in patients who have had COVID or vaccination, who have blood cancers. And there's been recently NRFF grants awarded looking at immune-compromised populations with the timing of vaccination and the appropriate scheduling for vaccination. So if you do have the opportunity to participate, please do, and certainly ask your clinical clinician, clinical team about those studies if they're available to you. So this is my final slide, and I wanted to bottom line it for everybody. There are many unknowns, and this will likely continue with the variants as they emerge, because not all variants are alike. And just because this, Omicron variant appears to be milder in healthy individuals, it doesn't mean that the next one will be the same or more mild. It could be slightly worse if anything. So we have to be prepared for that. You need to get vaccinated and behave as if you are not vaccinated. You need to practice caution. And you also need to be bold and brave and ask questions of your clinicians, your family and friends, and co-workers and service providers. If you go to a supermarket or a chemist, make sure that you are comfortable that they're catering for you. You deserve to be protected, and you deserve the consideration of others in your community and in society in general. The public messaging may not apply to you. So when you hear in the news about vaccination schedules and boosters, that's not intended for patients who are immune compromised unless specifically declared. So, it's important to understand that there's a lot of discussions in the media about mild COVID disease, but that is no guarantee that that applies to you. Vaccination schedules and treatment options are also different for you, as we discussed. So please ask.
Thank you, Nada. Thank you, Antoinette. Just a couple of questions, I guess I've got. Clinical trial patients, I wonder what your advice would be for them particularly.
Yeah, so it's really important to understand that clinical trials very early on during the pandemic created very specific protocols, like everything else in trials is very protocolized around COVID and around vaccination schedules. Some are permissive and will say, follow the guidelines in your own institution or your own state, and others will be very prescriptive about being vaccinated at whatever time points. I think in general, the advice that we talked about today applies to patients who are on clinical trials also. In fact, most trials would prefer that patients are vaccinated coming into the trial than to be vaccinated in the middle of the trial. But also recognize that immune compromise exists. And we are trying very hard to make trials safer as well. So, you know, most trials require patients come in for clinic visits and get examined, etc. And, you know, during COVID, we've moved a lot of our services to telehealth and virtual. But for clinical trials, sometimes it's still important to present to hospital and come and see your doctors. There's lots of protective policies around that, both from the trial and also from the hospitals, to make sure that you're safe to continue participating in the trial.
Thank you. Antoinette, can I direct a question to you? I just wanted to ask the advice of get vaccinated, act unvaccinated, which I know is very commonly heard now. How does that work with adolescents who are starting university or working at places like McDonald's, you know, that sort of adolescent world, I guess? What advice would you have for them?
Yeah, so I think, look, Nada has covered a lot of that in our earlier slides. I think vaccination is probably the key here, if it's safe to do that. And we note that there certainly are patients where there may be contraindications to get vaccinated. So seeking health advice is number one, and then following healthy practice. And I say to my young adults, and I have a very big adolescent practice, that it is important to have those rites of passages, the hanging out with friends, going to parties, starting university or finishing school. And so we have to think, well, how can we make that safer? So to be in a peer group with people who have the same values, who understand that you are immunocompromised and that are not going to take risks that put your life in jeopardy. To have to think about your workplace should have occupational safety advice for patients or for workers who are immunocompromised. So that might be having RAT tests daily. It might be increasing the cleaning facilities. It might be more social distancing. But I think people are often scared to ask because they don't want to be pigeonholed as someone who's immunocompromised. And my feeling when I've either gone to schools or universities is that people are really wanting to help. We want to keep our colleagues, our children, our families safe. And most organisations will help to make changes. And sometimes they won't, and if they won't or don't, I think about the champions that you have. So for example, the clinical nurse consultant, the social workers within the cancer centres can help to advocate within schools or workplaces to ensure that you have the right to continue life as normal. And so you should utilise those people.
That's great. Thank you.
Yeah, I would just quickly add is that, you know, as a clinician in adult medicine during COVID, I have written more letters than I've ever written to external stakeholders to advocate for my patients, from the workplace to travel agents to anyone that needs, you know, a nudge or an informed, supportive kick to help my patients. So we're happy to do that. We're willing to do that for you. So let us know if you're struggling and you need that kind of support.
And there's one question in the chat that sort of opens up. If you're post, say, 5 years treatment and you're in remission or cured, you're not, strictly speaking, immunocompromised, how does the vaccination schedule fit for you? Do you need a third primary dose, or do you have two and then a booster? What's your advice?
So I will
It's
take
tricky.
that one because I saw it in the chat around hospital performance. So number one, not all cancers are the same 5 years after treatment. So there's some cancers that need a very short treatment course of chemotherapy. The impact on the immune system is minimal because of the actual disease and the duration of treatment. And the further out you are from treatment, the less likely that you're immune compromised. So this is a really important question to ask your hematologist. Some patients, for example, with certain hematologic malignancies, for example, myeloma or CLL may be called in a remission, but they are likely to be immune compromised for life. So it's really important that you determine that with your clinician. The specific question about Hodgkin's lymphoma, I need to know more about that situation. I need to know if you've had multiple infections in the last 5 years. Are you someone who's behaving like an immune compromised patient, or someone who hasn't had a single cold in the 5 years since you've had your treatment? So it's not simply based on your disease and the treatment, but it's also based on how vulnerable you have been over time. And the best person to advise you on this would be your hematologist. As far as the third dose, it is looking very much like the COVID vaccine is going to be considered a 3-dose vaccine and not a 2-dose vaccine. So, you know, that advice will change for the general public, which brings me back to the point that general public advice does not apply to you, and it needs to be very tailored to your circumstance. So ask your clinicians. So I note there was a question in the chat that I really actually quite liked, and I might address that. The question is, you know, in the 30% risk of death of COVID for immune compromised people, is that 30% for all immune compromised people or 30% who actually got COVID? The data that I presented is specific to blood cancers. It's not all immune compromised patients, because immune compromised patients after a solid organ transplant or who have had a solid organ cancer is very different to blood cancers. Blood cancers are at the highest risk. And the data presented is the risk of dying if you have a blood cancer and get COVID. So of all the patients who had COVID and had a coexisting blood cancer, that's the risk of dying from it. That data doesn't describe the complications outside of death. And so there are many complications from COVID, as you've seen, in terms of its impact. So just because you don't die from COVID, you may experience some significant complications that may impact your quality of life and may impact your life, you know, and healthcare care in general, in terms of being able to receive treatment for your cancers, etc. So if you get COVID, you're at higher risk of complications than the average person.
Can I ask one more question? Sorry, I've just thought of it. If you're either pregnant or considering pregnancy, what would you recommend about vaccination?
This is a very good question. So it's been very clear that one of the major issues around COVID vaccination studies is that there was an exclusion of pregnancy. Like most studies, we exclude pregnancy. Everybody's too worried to expose pregnant women to these kinds of things. And this is an area of passion of mine. Because what happened during the pandemic is we noticed that pregnant women were very vulnerable to COVID. So the risk of dying from COVID while pregnant was very high. And imagine that loss. Imagine the loss of a mother and child due to COVID. Vaccination has become clearly a protective factor in pregnancy. So if you're planning to get pregnant, it's important to be fully vaccinated. If you've got the luxury of planning it, get vaccinated and plan your pregnancy. If you're already pregnant, there's data to show that it's safe to get vaccinated during pregnancy. I can say it here, but the best source of your information will be your healthcare provider that's helping you or supporting you during your pregnancy. So it's a very important question, because without a doubt, women who are pregnant are extremely vulnerable to COVID and its effects. It's the same with pregnancy. If you do get COVID while you're pregnant, it's really important to let your healthcare provider know, because again, we have those treatment options we discussed before, because women who are pregnant are considered vulnerable. It's not the same for blood cancer patients, but there's some similarities. Do you have anything to add about that, Antoinette?
Well, I don't look after patients who are pregnant, but I certainly know from the data, very, very important to think about the additional risks. And definitely, if you have cancer and you are pregnant, to be managed by high risk obstetrics teams who have a lot of knowledge about managing complicated or complex pregnancies, and then following the advice about COVID management is very important.
Thank you. There's another question from Chris about the data I presented, and I really appreciate Chris's interest in this granularity of the data. You're right, Chris, some of those patients were vaccinated, some were not, but we also know that vaccination doesn't necessarily confer immunity in blood cancer patients. And so the risk of death data is not really analyzed based on vaccination. There are some smaller studies that have shown that despite vaccination, patients with blood cancers remain vulnerable to the severe complications and death. So the rates are still roughly the same in those smaller studies. So that's why we talk about multiple doses, because the other piece of information that we have is the more doses you get, the more people tend to respond. So in 100 people, if we started off with 100 patients with blood cancers, 20 of them responded after vaccination with a double dose. After the third, you may get up to 30 or 40 of them having responded. After a fourth, you may get maybe 50 to 60. But again, that is based on very small numbers of patients. The true number, nobody really quite knows. So you will always improve your odds if you get vaccinated and get the boosters, if we're talking about odds.
And can you just mention Novavax, which has only just been made available in Australia? Is there anything particularly different, or should it be used for blood cancer patients? Do you have any information?
Yeah, specifically for blood cancer patients, that data isn't really there, as to, the specific impact on blood cancer patients. There's a lot of media and social media and misinformation around the different types of vaccines. And I tend to be very scientific about this approach, which is to look at the mechanism of action of each vaccine. So the mRNA vaccines are designed to teach your body to make an ineffective part of the COVID virus. So your body generates within messaging from your DNA to make a small piece of the virus, and then your body learns how to make antibodies to it. The Novavax vaccine is slightly different. It misses that step of teaching your body to make the protein. It just introduces the protein. Both mRNA vaccines and protein vaccines, which is what the Novavax vaccine is, have been studied for decades. There are more common protein vaccines out there, but the technology for both strategies is very well researched, and certainly in terms of safety, I would have no concerns in terms of safety with any of the vaccines. The question about mixing and matching comes up all the time. Many patients want to know, should I now ask for Novavax? Should I go get this vaccine? I heard it's better. Really, that's not based on evidence. We don't know what the implications are of mixing and matching the vaccines, other than to say, in some circumstances, in healthy patients, it may confer a slight advantage, but that may not be relevant for the different variants that are coming along. And for Novavax, if you want to get Novavax for your booster, go right ahead. I just certainly would not delay it because you want to get a specific vaccine.
Thank you, Nada.
There was a question about maintenance phase for oral medications for certain leukemias or illnesses. Is it the same? The answer to that is it depends on what kind of treatment you're receiving and what kind of chronic phase your disease is in. So I cannot stress enough the importance of discussing your specific situation with your clinician. None of your hematologists are going to get upset if you say, doctor, what should I do with my booster given I'm in this situation? Mm-hmm. In most instances, the advice will be get the booster. I don't know a hematologist that would say don't get the booster if you have had no reactions or complications with prior vaccines. If you've had your 2 doses, they will suggest a 3rd. If you've had 3, they'll probably suggest a 4th. Depending on your situation and circumstance. The timing may be something to ask questions about, but certainly I have advocated for boosters as much as I can in all my patients who are eligible. and the vaccine type. In very rare circumstances, if you've had a reaction or a negative outcome because you've had one type of vaccine, we have still gone ahead with an alternative. Mm-hmm. And we're lucky to have access to so many alternatives now.
Nada, there is a question in the chat, or Antoinette, around the side effects. If someone has experienced some side effects, can you just describe some of the common side effects of vaccination?
Yeah, so, one of the things I reflect on when I answer the question is the side effects that I had when I had the vaccine. That's how I remember them. And it's important to know it's normal to get side effects from vaccination. I remember getting the tetanus booster and feeling, oh my God, my arm is, really sore and I feel a little bit off for a couple of days. And that's no different for the COVID vaccine. COVID vaccination side effects really no different to most vaccines. And many of you may have experienced this where you get the flu shot and you think, I must have got the flu because I feel terrible. That really is a sign of efficacy of your immune system. Whether that is true efficacy or not, I'm not sure, but it's a sign that your body is responding to the vaccine. Common side effects include, symptoms of headaches, light fever, feeling aches and pains, feeling unwell for a couple of days. Depending on the type of vaccine, the side effect profile is slightly different. Those are the most common. Reactions at the site of the injection are also very common. So a sore arm, an itchy arm is not uncommon. If your symptoms persist for more than 2 or 3 days, that's not right. And so it's important to distinguish between side effects of the vaccine and something else going on. I had a patient who felt really breathless and she felt really unwell and had a fever and really attributed it to the vaccine because it happened 2 or 3 days after. She was still getting symptoms. It happened like a day or 2 after, but it turned out she had a blood clot and had nothing to do with the vaccine at all. She had a past history of these problems and she had a pneumonia and it was completely irrelevant to the vaccine. So I think it's important to appreciate that there are some minor effects. And when you do get the vaccine, every healthcare provider will give you information about what common side effects are. And if you're concerned or worried and you're not sure if, this is unusual or this is not right, or you're concerned, you must always ring someone. If you can't get access to your GP, contact your hematologist. Now, there are more serious complications to certain vaccines, particularly in younger age groups, and maybe Antoinette can discuss that. So with some of the vaccines, there's been a concern about pericarditis and myocarditis, which is inflammation of the heart. Now, remember, the way I think about this is that COVID is a disease that can affect the entire body with an inflammatory response. So it's possible that this impact is manifesting with vaccination as well. And although these side effects are rare, it's important to be aware of them. It certainly appears that pericarditis and myocarditis are more common in younger patients. We can talk about that in a moment, Antoinette, but there's other variants between the vaccines. For example, with AstraZeneca, there was concerns about certain types of blood clots that might occur. We're seeing less and less of that because that vaccine is not as widely available. If you're worried about those complications for yourself, worth asking the question, is this the right vaccine for me? Antoinette, do you have any experience with the...
Yeah, so again, when you look at the literature, certainly in the Paediatric and AYA, apart from the side effects you talked about, the things we worry most about is the cardiac side effects. And that is in the context that many of our blood disorder patients will also get a group of drugs called anthracyclines, and anthracyclines can also have an effect on the heart. So the recommendation from the ATAGI is, first of all, patient clinicians should not give the vaccine without further consultation from a cardiologist if patients have had either an abnormal cardiac assessment or cardiac symptoms. And then when you think about the risk of getting a pericardial myocarditis, the risk is actually very low. But it's important for patients to know that it's more common in young teenage males, but it can happen in any age group. The most common side effect is, the most common symptom, so what patients complain about is shortness of breath and chest pain. So if you have a vaccine and you have those symptoms, you need to go to hospital straight away. The good side when you look at the data is that for most patients, the side effect is very short-lived. In fact, the median time that patients are in hospital with this complication is 1 day. So for most patients, not all patients, if they do get cardiac side effects, they're likely to be very, very mild. But I guess the take-home message is, if you know that you've got a cardiac health problem prior to cancer, or cardiac problems as a result of cancer treatment, that you need to seek some additional advice from your cancer clinician before having the vaccine or the Pfizer booster shot.
I've seen another question that's a very good one that we haven't addressed today, and I thank you for asking the question. It is about vaccination after getting COVID. You know, there's a lot of patients who think, well, I've got COVID, do I really need to be vaccinated? You know, I must have immunity now. And the answer to that is probably not, because vaccination and COVID infection, if you're not likely to mount an antibody response, you probably have the same problem post-COVID infection. There's also evident in healthy patients outside of the blood cancer setting that if you've had COVID and been vaccinated, that offers a greater degree of protection from recurrent infections and severe infections in the future, rather than if you've just been infected and did not get vaccinated. The other thing to remember is, just because you've been infected with one variant, you are not protected from another, and that applies to even healthy patients. So the best approach is to maximize your odds at successfully fighting off COVID and getting vaccinated, even with your boosters, even if you did get an infection. The appropriate time for that, it's just common sense. Once you feel well enough, go off and get your booster if you're eligible for it and the time is right. Most clinicians would answer that question in that way. There was a lot of questions around when is the right time. Maybe it's 2 weeks, maybe it's 2 months. But really, once you're well enough, you feel recovered, you've got the clearance, if you want it, from your GP or your hematologist, go ahead and get it.
Someone's asking about blood clots. Blood clots are certainly something that we don't see as much in children and adolescents. So I'll ask Nada to comment after I've provided a comment. But what we do know is that cancer patients with blood disorders do have an increased risk of having clots. And so I think, irrespective of the vaccine or having COVID, it's really, really important that if you have symptoms that are outside of what you would normally have with your cancer treatment, that you need to take advice from your medical clinician. And the things to worry about are, you know, swelling, especially if they're asymmetrical. So one hand is swollen, one foot is swollen, severe headaches, shortness of breath or chest pain. They're all things that should make you think that you need to seek urgent medical advice and not be worried about coming to hospital. And I think that is really, if I have to have one take-home message, I've seen so many patients who have put off coming to hospital because they're worried about hospitals not being a safe place. And I think that, unfortunately, more harm is done by leaving things till later than by presenting to hospital in a timely manner. So really important to trust the people who are taking care of you. And, you know, I know from the chat, not everyone does trust their doctor, but if you don't trust your doctor, then find another doctor. There are plenty of hematologists and cancer specialists around, and it is very important that you feel that the team looking after you will provide the care that you require, or the care that your family member requires. And so I think that advocating for yourself and advocating for a loved one really have to be a take-home message. We are not saying that everyone should follow our advice and get vaccinated, although, I think Nada and I both strongly believe in vaccinations. But whether you're not vaccinated or not, you still deserve to have the very best care that, is available.
Thank you, Antoinette. And I think that's a really powerful message, I think, to finish on, and a very good takeaway message. But I would like to invite you, because there has been so much information shared today, that perhaps if you could give us just one or two of those really key messages for the audience to take away. I'll invite you, Nada, to go first.
I will focus it to three things.
Okay, great.
If you get COVID, let your hematologist know. That's my top message for all of my patients. I'm here to try and protect you as much as I can, whether you've been vaccinated or not, whether you're on treatment or maintenance, it doesn't matter. If you're my patient, let me know if you've got COVID, and I will do everything I can to help you come out unscathed. The second thing is, do not assume that the treatments that you're receiving are what you think they do. So a lot of my patients sometimes think the tablet that they're on is really just a tablet. Just a tablet can actually have a significant impact on your immune system, because by nature, if you have a blood cancer, you are immune compromised in one way or the other. And it's important to have that discussion with your hematologist about where you are in that spectrum and how you protect yourself, and create a strategy both for now and the future. And the third thing I would say is, it's really important for us to advocate for patients, but I spend a lot of time empowering my patients to advocate for themselves. I'm giving you permission, and I'm asking you to go out there and tell people and demand from people, including your community, your friends, your family, to help protect you. You rely on that protection because you can't do it for yourself for whatever reason, including your underlying condition. So engage with the people around you who love you, and even those who don't, you may demand it if you choose.
Thank you so much, Nada. I invite Antoinette.
Thank you.
Yeah, so look, I think I absolutely endorse all of the things that Nada said. The other things that I think are really clear from this pandemic is the impact on the psychosocial aspect of our lives. So, in addition to the concerns and worries we have having had cancer or being cancer survivors, it also impacts on work, finances, school, loved ones. And I think reaching out and telling people how you're feeling or what you need is so important, because it is a busy time, and all healthcare professionals are trying their best, but it's often the people with the loudest voice who are asking, who are getting access to support. So I would certainly say, especially for those patients who are on, continuous drugs, they don't see their health professionals as often, or maintenance, and our survivors who are a little bit more distant from the cancer centres, that if you are having any practical, financial, or mental health issues, to reach out. I would absolutely double up on terms of advocating and asking, especially when it comes to visitation. I think I'm not a supporter of, no visitors, no parents, or limited visitors, because I think the evidence really isn't there when it comes to supporting you during what everyone would realize is probably the worst time of your life. And I think there is a way in which you can continue to be safe without isolating yourself. And certainly I'm seeing in my practice people who have isolated themselves so much that in itself has become problematic when they are agoraphobic and so scared of leaving the house. And that is not living. The whole point of being cured from their cancer is living a good life and a full life, and that means being part of a family and a community.
Thank you so much to both of you. So that draws our webinar to a close. I would like to take this opportunity to thank, firstly, the supporters of the Leukaemia Foundation. Without them, we're not able to deliver education events such as these. Our amazing guest speakers, Associate Professor Antoinette Anazodo and Associate Professor Nada Hamad. We thank you for generously sharing your knowledge, expertise, and time in participating. And I think someone in the chat commented that it was done with such warmth, and I think that goes without saying. I think it's so important in how this information is delivered. And lastly, and most importantly, our audience, people living with blood cancer who have joined with us today. We encourage you to take the information you have heard to further these conversations, as Nada has said, with your healthcare teams, with family and friends, and with your entire communities. If you have any further questions or concerns, we encourage you to check out the COVID page on the Leukaemia Foundation's website as a primary source of current, relevant and reliable information.